All right, so let's get started. Good morning, everyone. You can see that there is a poll on the screen. If folks want to submit that, we'll share the results in just a moment. We're going to go ahead and get started this morning. Thank you all for being here. My name is Jamie Michael. I'm staff for the Wisconsin Public Health Association and the Wisconsin Association of Local Health Departments and Boards. I'll be your moderator for today's program. Thanks for sharing your Wednesday morning with us. WPHI is happy to be a partner for this webinar with Metopio and the Milwaukee Health Care Partnership for leveraging collaborative data to improve health outcomes. As the Wisconsin Public Health Association and other APHA affiliates across the country, we continue to support education and training for our members and public health allies. And today we'll gain insights into effective strategies for cross-sector partnerships and the pivotal role of data in shaping community health initiatives. If you are not, I'd love to encourage you all to get involved in WPHI or your own state affiliate and join as a member to support a collective independent voice for public health. Let's jump into today. We'll be stopping for Q&A at the end of the presentation, and we'll have some time for discussion. Questions may be submitted at any time by using the Zoom chat box. Please type your questions in there. We'll answer as many questions as time will allow once the presentation is over. I'm extremely excited to share our presenters this morning. Angie Grover enjoys helping partners turn complex community data into actionable insights every day. As co-founder and COO of Metopio, she leads go-to-market partnerships and customer success for the cloud platform now powering collaborative community health assessments in more than 30 states. Angie blends tech innovation with on-the-ground public health experience to help hospitals, health departments, and community-based organizations share data, streamline assessment workflows, and focus resources where they matter the most. Today, she'll share how automation and cross-sector collaboration can make the next generation of CHNAs faster, smarter, and more equitable. Justin Rivas, a former WPHA past president, leads community health initiatives for the Milwaukee Health Care Partnership, aiming to improve health outcomes and advance health equity through community-wide collaboration. In addition to overseeing community health needs assessment, planning, and Health Compass Milwaukee, Justin serves as the program director for the Milwaukee Enrollment Network, which works to address health insurance coverage and lower the uninsured rate. He leads projects around violence prevention, lead prevention, housing, and aligning social determinant of health referrals. Justin previously worked for County Health Rankings and Roadmaps. His role included providing strategic guidance and trainings in support of data-driven and evidence-based community action planning for health improvement, as well as developing national partnerships to support underserved populations. With that, thank you, Angie and Justin, for joining us today, and I'll turn it over to you all.
Awesome. Thank you, Jamie. And let's close that poll. And what we always like to do is find out why you showed up today to make sure that Justin and I cover all of the things that you are looking to learn. So what's happening in public health, how to get unique reports out of this process, ideas and tips for working with cross-sector partners, and the types of data that can be shared. So I think you'll be pleasantly surprised as we'll cover all of that and more. Our agenda today includes hitting on that data landscape and collaboration across all the different organizations, some real world examples of how Milwaukee in particular has shared data for their assessment, and talk a little bit about what's next locally and across the country. So my name is Angie Grover, and I am the co-founder and COO for Metopio. And before we get started, I always just like to center on this. We're going to talk a lot about data today, but I just like to remind us that data really represents the real lives and real communities, as well as the opportunities that we have in front of us to drive meaningful change. So I work a lot in data every day, but it's always really important to center around the people that we are looking to serve. So I'm going to jump right in, and I'm going to tee up a couple of these more landscape issues before I turn it over to Justin and let him talk about the important work that the Milwaukee Health Care Partnership is leading. But the elephant in the room really is what's going on with public data today. And so what I want to talk about is a little bit, so Metopio is a platform that provides not only data, but tools to help you with your analysis, your automated CHA and CHIP product programs, as well as sharing data effectively. And you'll see that kind of across the presentation. But a lot of the data that we curate for you comes from federal, state, and local sources. And so as we all know, kind of when the new administration came into office, what we saw was a lot of 404 messages on the websites that we use all the time. And so organizations like us and others who really do work with a lot of public data downloaded all that data, all that documentation, so we have that. What we've started to see is that some of those data sources are starting to come back at the federal level. We have a data science team who is really digging into what is being shared. Is it consistent so we maintain that longitudinal data set, or have they made changes? And so that's really what we're keeping an eye on. And we've seen, bits and pieces about how the next census might change, or, certain data sets that they said they were not going to release and now they're releasing. So it is a shifting landscape all the time. But what I'll say, there's a couple ways that we're dealing with this, because data to drive your work is so incredibly important, and we want to continue to share it. So the state of Wisconsin, and we work in almost all 50 states, and we find that state data is not being as affected. Now, there are some funding sources that might require those state data sources to go away or be funded in a different way. But lots of times what we see is that the state data is more granular and more reliable than some of those federal data sets. And as you all know, working with surveillance or maybe claims or other data, the data, really, the local data is a lot more rich and a lot more granular. So you can curate all of that within our platform. It's all de-identified and aggregated because we want to move you from that data to insight to action. And so there are, and you'll see some great ways, Milwaukee Health Care Partnership has collaborated around data, sharing data between the different organizations. But also you're having, what we're doing now more and more with our clients is, whereas you might have ran your community survey once every 3 or 5 years, depending on the cycle, we are now seeing people run it every year and try and hone in that community survey so that you're creating your own longitudinal data to close some of those community gaps. And we are based in Illinois, and Chicago Department of Public Health is really a leader. They have been running their community survey for 16 years. So they have a really robust, I think, proven hyper-local data set that they now use as the crux or the core of their community assessments. So that's the type of work that we're doing to understand what's happening at the federal level, really leverage more state and local data, which we're very adept at curating, and then working with you to understand what data you may want to create, or what data you have within your organization that you may be able to share to inform what's happening in the community. And this really goes to one of our core purposes, right? So we want to make sure that the data is usable. So part of what we do is take these complex data sets and make them very easy to visualize in maps, charts, and tables. And you don't have to be a data scientist. I'm not a data scientist. We have a data science team, but I can go in and look at a map. And, as human beings, we are drawn to maps. If you've ever given a data presentation and put a map up, somebody's going to ask you about something you're not showing because they see themselves in the county next door, or the city next door, or whatever it is. So that's just one of those quirky things about humans and how much we love maps. We have also designed this, as you'll see in the presentation, to be really multidisciplinary. So we bring together public health, hospitals, nonprofits, all together with the same data set. That gives us a shared language, that gives us more robust data in a lot of cases. And it saves us so much time and effort. Even part of where Metopio started was we worked in community health in an urban area, and there were 40 different organizations curating the same data sources and spending all of that time doing the data, finding it, cleaning it, curating it, when if you can have it one place that everybody can access, you free up months of work to actually go and move into the important part of the work that we do. We want to be data driven, but we also want to get out into the community and bring that lived experience in. So we're not just trying to put data up for data's sake. We're trying to make sure it's verified and curated, and that you have the information that you need to understand how to use it and what that data actually means. And I think the last thing that we've really learned in working with organizations across the health care spectrum is that workforce is very fungible. Our workforce is moving. I know Jamie just did a training for some new leaders in Wisconsin in the public health space. And what we want to be able to do is make sure that you have a resource that kind of weathers that transition. So making sure that everybody at every level can use data to drive their work, but that it's consistent and it's a reliable source so that you can pick up, right? If you're a new person, you can pick up right where somebody left off and you can understand what's there and available for your use. I did want to just acknowledge too that we have an exclusive relationship with NACHO, and one of the reasons that we have forged this partnership is because we really are one of the few platforms, or the only that I know, that has helped automate your community health assessment. So we're automating the things that should be automated and hoping to free up your time to do the things that require one-on-one engagement with the community. That's your focus groups, your key informant interviews, your your surveys, your prioritization process, all of that. Our platform means to support you in that process and free you up to do more of the human to human interaction, as well as moving those priorities into a chip module that provides you with a logic model and a way to measure progress with your partners. So that collaborative impact is super important. So we're very proud to partner with NACHO and to bring some NACHO member benefits in terms of member pricing and exclusive member benefits. So we are really trying to underpin the work that you're doing with our data platform. So that's kind of the landscape and why we believe that data is an important part of the work we do to actually tee up the tools that you need to do analytics and assessments in your community and track your progress. The Health Compass Milwaukee is built on the Metopio platform, and it is a dynamic platform. I'm just going to show a little bit. I think this is a little bit small, but just show you that this data is all available. It's forward facing. So if you're looking at FAB accreditation, Metopio's platform helps you meet or it either helps you meet or support 8 of the 10 fundamental criteria for FAB accreditation. And part of it is sharing data effectively with the community. So if you haven't already been, we're going to talk a lot about this, but Health Compass Milwaukee is something you can go to right now as we're talking through this and kind of play along and see what data is available and how you're able to use that. So this is just a high level look at what's available, but I'm going to let Justin dive a little bit deeper into that. And before I hand it over to Justin, I just wanted to share a few more learnings about this collaborative approach. So really, we believe in collaboration, and the way we've built our platform is to make sure you get something that's unique to you. So when we worked with NACHO, they did a survey and they found 76% of public health departments are collaborating with one or more hospitals on community assessments. I'm sure this is not a surprise to you. It was a surprise to me when I started working with our public health clients and finding out that sometimes the hospital comes to the public health department for the public health department to help them with their CHNA. Sometimes they're working collaboratively and maybe doing those focus groups and that survey together. There's so many different ways that you can collaborate. And I think with the pressures today, not only the funding, but just the environment that we've been working in, it is really a way to maximize resources if you can collaborate. In California, in fact, they're having the Medicaid payers as well as the public health departments and the hospitals all do one assessment together on the same cycle. So I think that's the other thing that we've observed is while FAB accreditation asks that you do this once every 5 years, we've seen a lot of local and regional collaboratives really try to align around a 3-year cycle because the IRS requirement is a little bit harder to change. And I don't think FAB minds if you do it once every 3 years. I think hospitals would prefer to do it once every 5 years. And if you think about the chip work that we do, it really does, and we're getting to the root causes of some of these health outcomes. So it does take time to stand those up, to measure that impact and to fully change the kind of the trajectory of health in your community. So really what we're seeing is that these community informed priorities are guiding not only the planning, but the implementation. And wherever you are in the cycle, you can come in and collaborate and make that part of what you do over and over again. And that having that shared data and priorities creates space for collaboration. And then, really, as Justin and I had prepared for this in advance of the Wisconsin meeting, and as we've talked along the way, is that this braided funding approach really is the way of the future. I think, at least for the current administration, they're looking at public-private partnerships. We know that the public health departments are focused on the communities that the hospitals serve. So there's a shared community that you're both working in. And these issues that we're trying to address are not ones that any one organization can really solve for. So we need to bring as many people into the process. And I know Justin's going to talk on this a little bit, but in my private life, I'm a housing first advocate. And, healthcare can't do all the work that needs to be done in housing. But if you lift this up and demonstrate the importance, you can bring in your planning department. Maybe you can bring in some of the developers. You can actually bring more people to the priorities that we align because they're very clear in their impact, and bring more people to the work of public health, which is really ultimately what we're after, is improving the health of our communities. And that is a perfect segue to what I think is one of the, premier collaborations across the country, and has been for some time now, and looking at how we work across hospitals, community-based organizations, FQHCs, academia. I don't know, I'll let you jump in here, Justin, because there's so many people to acknowledge. But it really, we are really proud to support the work that is being led by the Milwaukee Health Care Partnership and all the folks involved. So Justin, I'll turn it over to you.
Great. Thank you, Angie, and good morning, everyone. Thanks for all that kind of lead up to this exciting conversation. So I just wanted to provide a bit of background on the Milwaukee Healthcare Partnership, and I know some of you have probably heard of us before, but we're really a unique model, and I was actually really excited to come work for this organization because it is such a unique model in that it's a public-private consortium. So the healthcare piece is a bit of a misnomer because we have public health formally engaged as members as well. The healthcare sector is the one who really supports and sponsors much of the work. However, it's a public-private consortium of the four main health systems in Milwaukee County that serve beyond Milwaukee County. We have the 5 federally qualified health centers as members. We have the City of Milwaukee Health Department, Milwaukee County itself, and then the State Department of Health Services, DHS. And then as an academic partner, we have the Medical College, and we're also affiliated with the Wisconsin Hospital Association and Primary Care Association. So we're really a convening entity, but we're also a strategic funding entity, and bringing all these players together to really identify issues through the CHNA and then collectively invest in them. One other piece that's really important to name is that when people learn about the scale of collaboration, and by that I mean the healthcare partnership's been operating for almost 18 years now and has strategically invested near $40 million together. Bringing health systems who are traditionally, and I'm doing air quotes if you can't see me, traditionally competitors in markets, bringing them together to come to the same table and not just informally agree to work together, but formally collaborate and invest together is a big deal, because that's how we can potentially move the needle on some of these issues that intersect healthcare and public health. Next slide. So when we do that, is really the backbone of this work is through identifying needs together, and Angie laid out really well the importance of doing that. And I'm just going to give a little more context for folks that aren't familiar with Milwaukee, because we're a unique beast in terms of provision of public health and healthcare services. So Milwaukee County does not have a formal public health department at the county level. We have a city Milwaukee Health Department and I think 9 or so municipal health departments. We have a county Department of Health and Human Services. And then we have, as I named, the healthcare partnership operating at a county level, if you will. So when we do one community health needs assessment, for many reasons that you probably are looking into collaboration or collaborate to do this work, is we don't want to over-survey the community and have all those entities putting out health surveys every year, every quarter. And we want to be able to take all this data, provide one source of data for everyone to be able to utilize and kind of slice and dice to create the assessments they may need for their own organizational purposes. So what this slide is showing is basically we kind of have 3 main inputs of data for the CHNA. So we have the online surveys that we roll out in the community, or survey, I should say, key informant and focus groups, again, stuff you're familiar with, and then all the rich secondary data that exists on Health Compass Milwaukee that we spoke to a bit. And then all of this data is put together, and it provides a database, like I said, for each of the CHNAs for all of these different hospitals. We provide data for the federally qualified health centers to do assessment work that may align with HRSA needs. And then all of the municipals have a strong enough survey data set to be able to leverage for their own CHAs as well. Next slide. So what we wanted to do this next cycle, or this current cycle, I should say, we did our survey last summer into fall, so 24, and we're kind of doing the roadshow with all of the findings now for the CHNA in 25, is that we wanted to really kind of pivot into a digital CHNA. So traditionally, of course, 2 cycles back, we would do a phone survey, which is very costly, and ever since the pandemic, no one picks up their phone anymore, let alone to answer a 12-minute survey. So we pivoted both the kind of survey rollout and data collection, and we also wanted to pivot to a digital format so it was more kind of user-friendly in terms of not having to have people read a 40-some page report. And that's been really, I think, effective because of the quality of Metopio's product and how we are able to present this data. So it is the same layout and format that you'd find in the report. We identify the key top health issues. We've created a framework in 2024, and then we really want to drive people towards upstream and thinking about what are the health factors that they can work on to lead to changing these health outcomes and hopefully increasing health equity. One other thing that's important is because the healthcare partnership creates this shared CHNA report, it isn't aligned perfectly with the same kind of IRS regulations that a hospital needs or the FAB accreditation needs that a public health department needs. This collaborative CHNA, I think, is important because it's really a conceptual framework around health. And we're able to kind of talk broadly about the issues and maybe go a little deeper in some areas that maybe an individual health system wouldn't, and nudge others to think about how does housing or working with the unhoused population really affect health outcomes? How does working and partnering with public health and maybe some of the more progressive tactics they use really support healthcare access in a community? So I think that having one place to talk about these issues together is important. And an example of that is in 2024, besides our traditional CHNA report, we provided 2 kind of sub-reports of profiles. One was specifically on the connection between housing and health to really go deeper into really thinking about what housing means in terms of place, space, and economics. And I'll talk about that a little more in a bit. And then another sub-profile really looking at children, youth, and young adult populations to really understand the unique health needs there, and also aligns with our health system partner of Children's Wisconsin to think about what specific strategies might be important to focus on there. I think we are launching another poll. I'm seeing it pop up, and it also says that as a panelist, I cannot vote, so that doesn't seem very fair, but you all can vote. This is collaborative assessment. So the question is, are you currently or have you in the past produced a collaborative assessment with other organizations? Please take a minute to fill that out. I think another, as you do that, good question we could think about later on in the Q&A is collaboration and partnership is a spectrum, so it's important to me for me to think about, where everyone is along that spectrum of collaboration. What stage of readiness are you at per se? Are you kind of just getting things going in terms of collaboration? Are you 15 years deep in it? And we can kind of think about the successes and challenges you face along each of those kind of chronological roadmaps of collaboration, if you will. I think I probably talked enough to get through about 30 or 45 seconds for you to take that poll. So we'll close it. And do we want to share those back right away? Oh, there we go. Someone's doing stuff in the background for me. Okay. So about 7% said no, not collaborating. About 20% no, but are interested or they're collaboration curious, if you will. Yes, I will help hospitals with their assessment. So about a quarter of folks are engaged with the healthcare sector already. About another quarter or similar quarter with public health departments, and about 20% collaborative resources to complete my assessment. So a lot of you are very much in the collaborative space already. And I think that that's awesome because I think this conversation applies, and hopefully those that are not can learn a bit too. Next slide. Okay, so with our CHNA this time around, we really wanted to hopefully provide some framework that would make sense to both the community that took the survey, but all the organizations that work that intersect with health. So not just healthcare and public health, but thinking about all the community-based organizations, nonprofit organizations, philanthropy, other sectors that really want to have contributions in the health space, but needed somewhat of a conceptual framework to think about that. So we elevated, as you can see in the middle here, the top 5 health issues, very broadly defined in Milwaukee County. We have the arrows pointing to obviously how those relate to the health outcomes, very much rooted in equity and health disparities. And then importantly, we wanted to lift up the top health factors that really came out of all forms of data to think about where we could work upstream together and what makes the most sense for each sector to work in upstream together to have meaningful change happen in the health outcomes via the health issues. One other piece of this that I think is important is that while we were rolling through the CHNA in 2024-25, as you all know, working around the issues of DEI issues and health equity in general has been challenging for some sectors more than others, but we were able to really keep a strong commitment to health equity in this conceptual shared CHNA, and that helped some organizations that were meeting roadblocks or challenges within their own organizations on really committing to their equity work in name, I would say in the actual work, they're all doing it. But it helped us to kind of hold strong and have that firm line in the ground or in the sand, if you will, to drive those issues because it's come up in the data and we can't avoid it. It's such an issue in Milwaukee County when we look at health disparities and health inequities. Next slide. So this is just a kind of screenshot of what our website looks like. And I want to be clear too that the Healthcare Partnership has both a health atlas through Metopio. So that's the Health Compass Milwaukee, where it's a publicly accessible data hub, if you will. And then we also have this built out CHNA component as well. So what we like about this is that you can look at the CHNA as a standalone, point in time assessment report, but it also links to all of these indicators that are updated thanks to Metopio in real time so that you can see the most up-to-date data and really, if you want to hone in and get deeper with a specific indicator, you're able to narrow in on all the way down to census tract based on, if it's available in each data source. One other important thing we've done with Health Compass Milwaukee and through this partnership is we've leveraged a lot of hospital data. And why I think that's important is because we can look at things like what you're seeing here, if you can read that small, mental health emergency department visit rate by race or ethnicity. So we've worked through Wisconsin Hospital Association to gather data, feed it into the back end of Metopio, and then curate it to be able to look at very specific down to we can break down geography, all demographics, basically. You can disaggregate this data and really look at those, what you can see as sharp gaps in Milwaukee around hospital and ED use around certain issues. And I think this pairs well with when we're talking about, an issue like mental health, and we want to think about kind of what's in the lane of public health versus healthcare to do in this space. We can really identify the impacts that it has on the healthcare system, and that's for making cost effectiveness arguments to health systems. And we can talk about what could be done upstream for public health as well. So it's really helpful to do this. I think also in Wisconsin, there might be opportunity, since we do have this rich statewide data set, to build in hospital indicators, utilization, and outcome indicators for other jurisdictions as well. Next slide. So just quickly on what Health Compass Milwaukee is, and there's a QR code there that hopefully will take you right to the page if you want to click on it. Again, this is our broad community data resource, I would say. And what's helpful with this resource is that, again, it doesn't just, I would say our super users are healthcare and public health, but we're able to kind of point our philanthropic partners to this. We're able to invite a lot of our community-based organizations that do a lot of grant writing work, and they can really utilize this data and also look up some strategies here as well that we'll talk about in a bit. We are able to we have a lot of faith-based organizations that want to know more about health in their community, and we can point them to this. So this is a resource truly that serves a lot of different organizations and sectors and is at the moment stood up or by the healthcare sector in terms of kind of who pays for the back end, but is a really helpful and utilized source of truth of data. And we've been able to kind of see that in the numbers too. So we use Google Analytics to kind of look at the how many people access the site and use it, and we have pretty strong performance numbers in terms of how that's done. So it's good to know that the kind of return on investment of the site is helpful for the community and being utilized in real time. Next slide. So I want to talk a little bit about just a few example issues, and I did a little bit already on Health Compass Milwaukee and how we've kind of taken this CHNA site and built into the back end some of the data that sits on Health Compass Milwaukee. So specifically on the top health issue of mental health, this would be what came up as our second issue after violence this year. Again, we were able to merge some hospital-based data. We're able to look at it broken down by race and ethnicity, because what we'll see in Milwaukee County is that mental health in the last two CHNA cycles has risen to the top or near the top as the top health issue, I would say, across the entire community. And while that exists as a top concern across the entire community, there's actually really sharp gaps in Milwaukee County in terms of who it's impacting. And who it is impacting in Milwaukee is really Black African American more so than white, and younger populations. And we'll see that in ED visit rates. We'll see that in suicide rates. So it really helps us identify a specific subgroup population that we can narrow in implementation strategies with and do that work collectively across the community. And it's also important to understand that this work, while it's informed, I think, mental health specifically as an issue, when we're looking at hospital data, the way I always talk about it is that's just the tip of the iceberg, right? So if we're trying to define the mental health concern in our community by who's showing up in a hospital emergency department because of a mental health issue, that's just the tip, right? So we're really need to identify and work more upstream to understand the broader populations that's impacted by this. Next slide.
Justin?
Yeah, we got some.
There is a
questions.
question
Sure.
in the Q&A, and I think this is showing some disaggregation. So it says, has MHCP considered including stats by municipality within your CHNA, either one-pagers for data at a municipal level versus county, or something like a data appendix with crosstabs by municipality for survey responses? And do you show any of that on Health Compass Milwaukee?
So the quick answer is yes. I think I missed this actually, and that's a great point. So whoever wrote that in, I appreciate it. What we were able to do with Metopio is take our survey data and build it into indicators on Health Compass Milwaukee so that they're actually indicators. And so I think we had 52 questions on our survey, and I think we created, not all of them were kind of the right data to create indicators. So I think we created over 20 indicators, and we have the survey data living on Health Compass Milwaukee. And then you can actually map that data as best as we have a strong enough sample to create that you can. Also, what we did is for each of the municipal health departments, we were able to curate this data for their kind of municipal geographies or jurisdictions and provide that as well. And then if this is someone who's local, who's actually really interested in this, we can work with our data consultant locally to slice and dice some survey data for you if you have any interest in that. So yes to that question overall.
And then it looks like Paige has her hand up. I'm going to see if I can operate this. Paige, I think if you unmute, you can ask your question now. And if not, feel free to type it into the chat and we'll get it to Justin or Jamie or myself as that's relevant. So I will let you keep going, Justin.
Yeah, great. You can pivot. Yeah, so then I just wanted to give another example because I think, or I know from my experience in this space, talking about the connection between housing and health, housing comes up as a top issue regularly for us. But talking about the intersection between housing and health, and specifically what can be done to address housing, because it's so broadly defined, is a challenge that we face through the CHNA. So we were excited last time in 2021 with the CHNA to just have all of the organizations acknowledge housing as the driving issue. in terms of social determinants of health. But then we wanted to go deeper in terms of kind of characterizing different housing issues and which populations are most impacted by it. Because it's one thing to say we want to address housing, but then it's another thing to say, well, where do we actually invest and what do we actually implement in order to do that? That makes sense coming from a healthcare, public health lane. So because we have indicators to do this, we broke down the issue of housing into kind of three buckets here in talking about where your housing is placed in the community. And that's important because it helps us talk about issues like in Milwaukee, we live in a hyper-segregated community. We can talk about what that means for environmental conditions across the community. And we can also talk about, based on where you reside in the community, what that means for community safety and transportation access and other social determinants of health. So looking through housing in that lane and vein. We can actually talk about the space of housing, and we have indicators in Health Compass for each of these, right? So we can talk about housing quality issues. We can talk about lead exposure. One indicator we use is just housing built prior to 1978, and then also a marker for prior to 1950. And Milwaukee, for example, over 80% of the housing stock is built before 1978, so very old housing stock. But then when we look at another indicator around childhood lead poisoning, we'll see that the childhood lead poisoning is very much concentrated in certain parts of our community, even though the old housing stock exists all over the community. And of course, you can presume that's because there's more access to resources and wealth to abate homes and public areas in those more wealthy parts of the community, and other areas do not have those resources. So a way to talk about those issues. And then also, in terms of economics, we think it's important to elevate what housing means as an economic driver in terms of kind of financial stability over time and building intergenerational wealth. And then that lets us hone in on an issue like you're seeing on the screen here of housing cost burden and what that really means for households, not just traditional housing cost burden, which is spending 30% of your income on a monthly basis on housing costs, but also severe housing cost burden, which is spending 50% or more on both mortgage or rent, to help identify those communities that are really facing challenges in affording their housing as it is, not to mention potentially the quality of that housing, but then thinking about what it means for other communities that are able to really build intergenerational wealth that we know leads to better health outcomes. Next slide. So then just going a little deeper on this housing connection is in the housing profile with the CHNA, again, being able to kind of leverage all this data to create contextual frameworks. We wanted to link the issues of housing with poor health and financial instability, and then link it back to those key indicators that live on Health Compass Milwaukee, so that we can talk about the issues in community spaces and connect these, what we call a vicious cycle that's rooted in poverty. But then we can also point to specific data and areas in which to work in these areas. And I'm not going to read through each of these kind of blocks in the framework, but it helps us to understand maybe where points to intervene in this cycle and what it makes sense for most sectors. So if we're partnering with the county's housing division on what the work they're doing to address the homeless population, we can think about, what does that mean for the poor health outcomes we're seeing for that population showing up in hospital emergency departments, and connect back those issues together. Next slide. And then just to go a little deeper on an issue that's been very top of mind in Milwaukee County, is talking about the lead issue. And if for those of you that are based here or have interest, there's been a lot of coverage in the news about lead in public spaces, specifically in the school district in Milwaukee Public Schools. But we really wanted to address the home environment in the issue, but we worked with the health department to get really excellent data, which you can see in the second map here of pooled prevalence of confirmed childhood lead positivity testing. And then think about what that means for according to housing stock as well. And I kind of talked through a little bit of this on the other slide, but it helps us identify kind of key neighborhoods to work in these areas. And also it's helped us to leverage the importance of this issue and knowing that housing is the key driver to work in certain communities to do outreach on lead testing as well, and to increase the lead testing support and services across the healthcare sector in Milwaukee as well, because that's one of the challenges too, is that this is a complex and wicked issue, and that we have transient low-income populations that are often changing residents or households. Those households are often owned by landlords, and then the city is often working to abate those homes that are owned by landlords, and you're not necessarily addressing the health issue for the specific family that was living there at the time that the positive test was confirmed. So I know very nuanced and detailed, but we have the data available to us and living on Health Compass in order to kind of think about how to address that problem from both the housing abatement and also the childhood-led testing side. I think that's my last example of just the myriad of ways we use data and are able to have that data live on Health Compass Milwaukee. And we've highlighted it through our CHNA. I think at this point, I'm handing back to Angie, perhaps.
I think handing back to me, Justin. Thank you so
Oh,
much.
yeah, handing back to you. Otherwise,
Yeah.
I'd be happy to talk about some of the chip work too. And I don't know if Angie was going to hand, but I'll let you jump in, Jamie. Yep.
Okay. Well, I'll just pause there. I'm curious if there's any questions. Paige, I didn't see you were able to put anything in the chat, but we'll maybe pause for a second for questions if anybody has any that we can address, and then you can go into the chip stuff if we have a little bit of time yet.
There is one from Carrie in the chat.
Yep. So I'm not sure exactly when this happened, Justin, but how come the hospital data doesn't have AIN as race? It's a very specific question.
Sorry, I didn't hear the last part.
How come the hospital data doesn't have AIAN as race
Oh,
in the
that
mental health slide?
yeah. That might be because the size was too small of the subgroup. That would probably be the reason. It is provided in the hospital data to
Yeah.
the best of my recollection, but it might be too small of a subgroup. Angie might know it better too.
Yeah, that's typically the case. So part of the challenge in sharing this data and just recognizing population data is that sometimes with suppression below the county level, there are no data to show because it's suppressed. And so that's part of the challenge with sharing data that's de-identified and aggregated for some of those subpopulations. But it does come to us, so where it's available and we can demonstrate or we can show it safely, we do.
And just really quickly, one way we've kind of worked around that issue in Milwaukee locally is so on the survey, we do ask about that subcategory on the survey, and we were able to cross-tab the data. So we have survey data for that, which doesn't speak to the hospital data, I know. And then we also worked with the local, so I think Milwaukee is one of the few urban American Indian Alaskan Native serving FQHCs and identified their specific catchment area, and we're able to cross-tab survey data based on that as well. So those are just other ways we've kind of triangulated at looking at that subpopulation.
All right, thank you, Justin. There's one more question. Could you share a little bit about the agreements, or do you have to have agreements to work together on a collaborative CHNA or CHA?
I think some form of agreements are always good. Yeah, so that's a great question. And if you want to get to kind of the brass tacks of how that works, we have the 4 health systems in a formal collaboration together. They contribute portions of their community benefit dollars on an annual basis to support what we call shared community investments, and that fund is called the SCIF fund. And that funding work helps support Health Compass Milwaukee, and it helps support the shared CHNA. So those are directly from their budgets, and they all see value and utility in that. We also were really excited this year to have, I know it was on the first partnership slide, but to have the City of Milwaukee Health Department formally aligned, and they were amazing to align their 5-year cycle with this 3-year cycle. And the county doesn't have to produce an assessment since they're not a public health department, but they align some of their strategic planning. And we have, agreements with them to do that work. To the extent that it's contractual, depends on the organization, but it's helpful in a lot of our other work that we do strategically. There are formalized agreements, yes.
Thank you, Justin. One last call for any questions. All right, there is one final poll left for folks to add in their feedback. I want to thank Angie and Justin for presenting this afternoon now that we're past 12 o'clock. Thank you so much for your time. Thank you everybody else for joining us here this afternoon. The recording will be available and will be sent to all of you as registered attendees. And we'll look forward to sharing more information about data and Metopio and our continued partnership